Before I start, I want to tell a quick story. Over the weekend, I ran in this crazy race called the Bourbon Chase, which is this 200-mile race across the state of Kentucky. You do it in a team of 10 people or so, run about 20 miles each. And I learned a couple of things while I was doing that. The first thing I learned was training is a good thing. Probably should have done a little bit of that before I tried to run a marathon distance. But the other thing that I learned is that while I'm running down these paths, I'm passing multi-million-dollar horse farms with these huge barns, and these horses are taken care of better than most people are. And then you run another mile down, and all of a sudden you see these shacks, these houses, if you can call them, that people are living in, where they literally have outhouses, they have stacks of wood, where they clearly don't have central heating. And I start to wonder, do those people have primary care? Are those people eating the right things? Do they get enough physical activity? The answer is no. There are a lot of health disparities out there that need to be addressed when we think about comprehensive health and population health. So I'm going to talk about today how Humana is trying to convene lots of different stakeholders to really address health disparities and inequities in health. So I'm going to start by stating the obvious, right? Health is hard. Everybody knows that. We're all less healthy than we were 10 years ago. A lot of us are sedentary. We have desk jobs. We eat fast food. You see the rates of obesity and diabetes and heart disease are all on the rise. So health is hard. I'll share a couple of statistics. You can see nearly 1 in 11 people in the United States has diabetes right now. That's a shocking statistic to me. And that really is just the tip of the iceberg, right? There are lots of people that are undiagnosed but have diabetes. There are millions of people with prediabetes, and 90% of them don't even know about it. And then you have this avalanche of people with obesity that are at high risk for developing diabetes over time. 1 in 7 people in our country don't have enough food to eat. That is another really stark statistic to me. Food insecurity is the term that we use to talk about this. And, in some cases it really is talking about people not having enough food to eat. But in other cases, they're not eating the right foods. They're eating high-fat, high-salt, highly processed foods. And the issue there really is more about access. It's access to healthy foods. They may live in a food desert. They may not have transportation to get to a grocery store. They may not be able to afford healthy foods because, as you all know, you can go to McDonald's and get a $5 Happy Meal, and you can feel full. But if you go to Whole Foods or you go to a grocery store and you try and buy healthy food, fresh vegetables and fruits and so forth, it's a lot more expensive. So, food insecurity can kind of come at it from a couple of different ways. Something else you guys probably all are aware of this is the obesity rate in the United States has tripled in the last 30 years. Last 20 years. And, that again is due to a sedentary lifestyle. It's due to us having a poor diet. Lots of factors involved in that, some of which is by choice. But others it has to do more with, the environment. Are there walking paths? Are there parks available? Do people feel safe going to those parks, because of violent crime and other reasons like that? There's lots of reasons, and it's easy just to say people are making bad choices, but I think what we really need to think about is how do we make good health the easy choice? How do we make it an opt-out sort of situation as opposed to an opt-in situation when we think about health? Another one here is 1 in 25 Americans has depression or bipolar disorder. Behavioral health is a condition or a group of conditions that we don't talk about as much because even now, even in this day and age, there's a stigma attached to this. There's a stigma associated with these conditions that people don't want to talk about. But what we see in our data and talking to our members is that, in some cases, these conditions exist by themselves. You can just have depression or anxiety or bipolar disorder. In other cases, they exist as comorbidities to other chronic diseases. And what we find is that if you have diabetes and you have comorbid depression, you are far less likely to take your medications, to do your lifestyle changes, and things like that, and you end up having worse outcomes in the long term. So Behavioral health in general and depression in particular is an area that we are focusing a lot more on now, and I believe that our society in general should focus on more. We should reduce the stigma associated with it, and we should support people that have these conditions and treat them like any other chronic condition that we deal with. So all this to say that our system is out of balance. I think that's fairly obvious by this point, but it is. We spend a lot of money in this country on healthcare, and we're not getting the outcomes that we should be getting. All these rates of chronic disease and everything else are getting worse, not better, and we're spending more money, not less. So here's something else that, again, some of you may have seen this before. We spend $10,000 per person per year on healthcare in this country. That is $3 trillion that we spend on healthcare. And that is a ton of money. And you would think that if we spend that kind of money, we should be getting good outcomes for it, right? But the problem is we're spending all this money on sick care. We're spending it on people with chronic diseases. We're spending it on hospitalizations. We're not spending it on things like prevention, on wellness, on health in general. So if you just look at the left side of the slide for a second, think about what does that $10,000 buy us right now? Well, we are number one in the world in healthcare spending. So, should we start a chant of USA, USA, right? Because we're number one there. But if you look over on the right, you see we're 26th in life expectancy, which is ridiculous that we spend that much money on healthcare and we're that low in life expectancy compared to all these other first world countries. We talk about socialized medicine, we talk about all these other things, but the fact of the matter is we spend far and away more money than any other country, and we're getting worse outcomes. And this is the reason why, right? This kind of puts it, encapsulates the issue is that we spend money, you can see on the left, we spend it on medical services. Like I said, we spend it on hospitalizations, we spend it on treating chronic diseases. We don't spend it on healthy behaviors. We don't spend it on prevention. Now, if you look over the right, it says this is what makes us healthy. What makes us healthy is, in part genetics, in part it's environment, which we should be influencing, it's access to care, and it's healthy behaviors. Healthy behaviors are 50% of what makes up our ability to be healthy. So that's what we really need to be thinking about. How do we support healthy behaviors? How do we help people eat better? How do we help them be more active? How do we help them manage their chronic diseases so they can be healthy and live healthy, quality lives? So this is it. We are paying way too much and we're getting way worse outcomes than we deserve. And we need to do something about it because people are getting sicker. Like I said, obesity rates going up, diabetes rates going up, everything else is going up. We're spending all kinds of money and we're not getting the outcomes that we need to get. So one more example, and you guys may have seen this before, but 20 years ago, this was the heat map, the picture of diabetes in our country. And what you can see is that the majority of states, almost all of the states really, have less than 5% prevalence of diabetes. Okay? So fast forward 10 years. Every single state in this country has more than 5%, and about half of them have over 6%. Right? That's pretty significant. In the country with almost 400 million people, we're going up at that kind of rate. And then if you go forward to today or 2 years ago, you can see that almost every state here has above 9% diabetes. So we've gone from all states having less than 5% to almost all states having above 9%, basically doubled in 20 years. That's really, really significant. That is a huge disease burden, it's a huge cost burden, it's a huge quality of life burden that we're faced with. And something has to change. And that's why, Humana, the company that I work for, is really pivoting from what we used to be as a company to what we want to be in the future. And this is what it is. And frankly, I'm kind of surprised that my leadership allowed me to say this out loud, let alone put it on a slide. But the reality of it is, 10 years ago, we were a utilization management company. And what that means is that our goal was to basically cut down costs by keeping people out of the hospital. We were a gatekeeper. We would decide who could go into the hospital and who couldn't go into the hospital. Not proud of it, but that's where we were. Then we realized, we've got a lot of sick people with chronic conditions. And just as an example, in our Medicare population, we have over 30% of them have diabetes, right? And our Medicare population is nearly 4 million members. That means over 1 million people just in our Medicare membership have diabetes. We had to do something about that, so we pivoted to disease management. And that's really where, okay, we're going to have these programs, these telephonic nursing programs, where we're going to help people with chronic disease. And that's good. It's a step in the right direction, does the right thing. But what we realized over time, though, is that, just calling somebody on the phone and saying, do better with your diabetes, take your medications, doesn't do the trick. Because a lot of times what we were hearing is that, well, you know what, I'm on a fixed income, and I'm making choices between buying groceries for my family and filling my prescriptions. And when I'm faced with that choice, I'm buying food for my family every single time. And so something finally clicked where we realized that it's not even just about disease management, but we've got to talk about population health. We've got to talk about community health. We've got to talk about prevention. All those things are absolutely critical to us, supporting people with their health. It's true for our company. It's true for our members. It's true for the country as a whole, is that we really need to focus further upstream with health and talk about prevention and talk about supporting a healthy lifestyle so that we don't have to deal with disease, so that we don't have to worry about, who's allowed to go to the hospital and who's not. So the first way that we're attempting to do this is by changing our relationships with providers, right? Providers are the trusted source for patients when they have healthcare needs. And so this is kind of the traditional model. It's a simple depiction of it, but it's a traditional model of what it's like to go see a doctor, right? Patient goes to see the doctor gets paid. It's a fee-for-service model that we've all kind of grown up with. The challenge, though, is that it's a one-off interaction, and in order for the physician really to make money, you've got to see a lot of different patients, right? 40 or 50 patients a day in a primary care setting to keep the lights on and pay your staff and the overhead and all that kind of stuff. Not really efficient. It's not really focused on outcomes. It's focused on seeing as many people as you can. In a new model, we think about how can we support providers outside of that office? What else do patients need to support their health beyond just coming in with a presenting complaint or coming in and adjusting your medications? And so these are some of the things that we kind of think about. We think about, well, we have in-home care, in-home programs where we can send a nurse practitioner or a social worker or another clinician into a home to help support someone's health. We leverage data, right? How can we use data to support providers? Well, we can tell them who hasn't had an A1C done in a year. Or if we get lab data now, we can see who's got high cholesterol, who's at risk for a stroke or an MI, different things like that. We have assets where we can help synchronize medication refills so you don't have that gap between running out of medications and having to go to the pharmacy to refill it. And even beyond some of these more traditional healthcare things, we're also looking at how can we support with addressing barriers to health. And that's the one you see over here on your left. And that's, it's kind of crazy to think about an insurance company or even a doctor helping connect a patient with a food bank. That's really kind of a profound thing to think about. But if food is an issue or transportation is an issue, these folks are not going to be thinking about their health care, about taking care of their diabetes if they can't even get to the doctor office, or if they can't afford food, or they can't feed their family, right? So you have to kind of think about a person holistically when you want to support them in their health, and that includes root causes of poor health and health barriers and things like that. So this is the model that we're trying to get to, right? If we talk about population medicine, which I just kind of spoke about, and you combine that with value-based payments, which we're also transitioning to, that's when you get value-based care. And the way this works is that you're aligning incentives, right? You're not paying doctors to see lots and lots of patients. You're paying for outcomes. You're paying for quality outcomes, and that's really what we want to get at. Well, you can't do a value-based payment model or even population medicine without data to support it. You have to know when you need to see a patient, what you need to see them for, different things like that. And you have to have the supporting assets of, care management and supporting with some of these other kind of social determinants of health as well, if you're going to do this right. But this is what we're trying to get to. The second thing that we're trying to do is really focus on what happens outside the doctor's office. So most of us might only see a doctor once a year. If you have a chronic disease, it might be 3 or 4 times a year. But most of us live 90 to 99% of our lives outside the doctor's office. So as a company, Humana starts to think about what can we do to support health outside of the doctor's office. So this is kind of the traditional scope of the healthcare system. This is a patient on the right. You can see kind of the healthcare system on the left. A patient will interact on a one-off basis when they need to go to the ER, when they need to go to primary care, a specialist, or get a lab done. They're kind of doing that in sort of a one-off basis. They're not really being supported outside of that. They're going to get healthcare when they need it, and then they go home, and then they go back again when they need it again, but that's basically it. But there are all these sort of non-traditional areas of health that need to be addressed in addition to that 10-minute office visit you can have with your doctor. And some of these I've talked about already, but it's making sure you have transportation to get to the doctor in the first place, making sure you have access to healthy foods. You can see a lot of the different things, leveraging technology, all these other things that are a little bit sort of out of the scope of traditional healthcare, but we need to bring those in. We need to think about all those things that contribute to sort of overall health. And so this is the model that we're striving for. We want to create a model that is patient-centric. We've talked about that, at various times throughout the day, but really being, consumer-centric, patient-centric, however you want to describe it, but combining all these sort of attributes of traditional healthcare with some of these non-traditional things so that you're treating a patient holistically, that you're addressing their conditions if they have them, but you're also thinking about prevention, and you're really thinking about root causes of poor health, social determinants of health, and so forth. One of the ways that we do this is by developing partnerships with local and national organizations. You can see a couple of them here. But I've mentioned food and food insecurity a few times. Well, we've got a partnership with Feeding America, which is one of the largest sort of nonprofit charities in the country. They are the thought leaders, the experts in food insecurity and hunger in general. So we have a partnership with them, talking to them about how do we address this? How do we do this right? How do we partner with providers? And that sort of thing. We also partner with the Y. We have a really deep partnership with Robert Wood Johnson Foundation because, as I said, in addition to talking about chronic conditions, as we move upstream, we need to look at root cause of health. And Robert Wood Johnson Foundation are the experts in understanding social determinants of health and how crucial those are to overall health and quality of life. So those are a few of the partnerships that we work with. So, what it really comes down to is that we are pivoting as a company. We are changing our strategy and our approach, and our goal really is to change that for the industry and really the country as a whole. We want to create a movement around health that really starts to look at prevention and starts to look at root causes of poor health. Because ultimately we want to deliver better health outcomes, for our members, for the communities that we serve, and for the country as a whole. The way to do this is that we set a bold goal. And our bold goal is that we have committed to improving the health of the communities that we serve by 20% by 2020 because we make it easy for people to achieve their best health. So that's kind of a big mouthful. But essentially what we want to do is we want to improve health by 20% by 2020, which is a really, really bold goal. Frankly, we may not achieve it, but what we want to do by this is be inspirational, be aspirational. We want to start a conversation about how we address community health and population health and how we begin to make progress in the right direction. In addition to being inspirational and aspirational, it has to be quantifiable, right? And that's really, the data aspect is what really kind of gets me excited. It's my role on this population health team is to lead all of the metrics and the analytics and the research that go behind this. The first step in that is to figure out the metric that we're going to quantify our 20% healthier goal by. And what we came up with was CDC's Healthy Days measure. It's a really, really simple survey, but it's really comprehensive and sort of elegant in its simplicity. And what it is it's basically two questions. It asks, in the last 30 days, how many days have you been either mentally or physically unhealthy? I mean, pretty simple, right? Two questions. But when we ask that, it's really a reflection of how people feel about their health, and that's the intent, right? Is how do you feel about your health? Regardless of what chronic conditions you have or other circumstances, how do you feel about your health? And when we use that metric, we can establish a baseline, first within our membership, but also community-wide and nationwide, and it's something that we can trend against. And our goal, our 20% goal, is to improve healthy days by 20% by 2020. So once we establish the goal, then it's really more about the approach. What are we actually going to do? How do we get boots on the ground? Well, this is where we start, right? We want to leverage data, but we also want to listen to the community. And so what you can see here is a data visualization tool that we developed called our Community Health Dashboard. And what we've done here is that we've taken all the data that we get, everything from claims, from labs, from EMR, and we put it all into here, and you can see this is just one particular community, but you can go zoom all the way out to a country, you can zoom all the way into a county level. And what it tells us, the prevalence of chronic disease, basically disease burden, the cost associated with it, the utilization associated with it, hospitalizations, ER, et cetera. And then over on the right, what we've done is that through our partnership with Robert Wood Johnson Foundation, we have imported all of their data from their county health ranking report that they send out each year with all the social determinants of health. So again, all the way down to a county level, you can suddenly see what are the really important, really highly prevalent chronic conditions, and contrast that with what are the major health barriers or social determinants of health that need to be addressed in a given community. And so what this does is it allows us for, if we're going to go into a new community, we can use our tool here to figure out what are the top 2 or 3 conditions, what are the top 2 or 3 health barriers that we really want to address in that community. And now we get that from the data that we have, but that's not enough, obviously. So then we go into the community and actually talk to stakeholders that are there in the health department and clinicians and other folks to figure out, are these the right things that we should be focusing on? Because sometimes, data doesn't tell the whole story. You actually have to speak with people and figure out. And just one example of what came through those conversations is that, through a lot of our data, we found, it's the sort of usual suspects. It's diabetes, it's heart disease, it's COPD, things like that. But when we went into communities, they said, well, yeah, that's all true, but what you really need to focus on is behavioral health. It's depression, it's anxiety, it's bipolar disorder, it's other things like that. And that didn't come up in our data right away. Maybe we weren't looking at it the right way. Maybe we don't get claims from it. Who knows? But, that was an insight that came from the communities that said, that's great, but you're not really going to make a dent in diabetes until you start talking about depression. So that's fair enough, and that really helps us. And that, it builds trust within the community because they, the folks that we're talking to recognize that we've got a lot of really good data, but that we're sort of, we're verifying it with people that are on the ground experiencing these sort of health things. So quickly, this is our approach, at a really high level. We call it our journey to impact. It starts, as I kind of started to say, is by building trust in those communities. We want to go into these communities. We want to meet with all the different stakeholders, and that's government folks, it's nonprofits, it's for-profits, it's clinical folks, it's faith-based organizations. We want to meet with all those folks and really talk to them about what are the key sort of health issues and health barriers that we need to address. Then we want to form partnerships. Talked about that a little bit already, but we've got these kind of key thought leader partnerships at a national level, but we also want to have partnerships at the local level, local nonprofits, local government organizations, et cetera. What comes out of those partnerships are sometimes new pilots and programs and services. Other times it's just highlighting and coordinating those that already exist in the communities. But what that really drives is more participation by the patients, by the people that need it in those communities. And so when you get participation in those programs, that's when you get behavior change. Behavior change can be improved diet, it can be more physical activity, it can be stabilization of chronic disease, et cetera, et cetera. And when that happens, then you see improved health and lower costs. So I'll talk a little bit about each of these things, but that in a nutshell is kind of what our approach is. So it starts by building trust. I mentioned that we go into those communities and talk to the local stakeholders. The way we do that is we go in and we host a clinical town hall. And these town halls have 200-300 people that come to them. And again, they're all the local stakeholders. We want everyone there. We want nonprofits, we want for-profits, we want faith-based, we want government, we want clinicians. We want all these people here so that we can really sort of narrow down on what are the key health issues and health barriers that we need to focus on in a community. What happens after the town hall is that of those 300 people, we invite them to join a newly formed health advisory board. And the health advisory board is really kind of the work group that's going to stay together and meet on a regular basis, really kind of look deeper into some of those chronic conditions and health barriers, form subcommittees, and eventually launch new programs or coordinate programs and services that are already available within those communities. So that's our approach to building trust. What you can see here, oh wow, that didn't show up all the way, but that's meant to be a map of the country, showing the communities that we're in. We have 7 markets where we are right now, and we're expanding to 3 or 4 other ones. But what you can see are just some kind of statistics about the people and organizations that we've interacted with so far. Through our town halls in those 7 markets, we've hosted 1,400 different people, stakeholders, community leaders that we've engaged with on key health issues. Of that, once we form our health advisory boards, we have 340 different organizations involved in those health advisory boards, those that have come to the town hall and then committed to staying engaged with the work that we're trying to do. Within those health advisory boards, we form subcommittees. Like I said, we've got 28 of those across 7 markets. And when you think about it, what we're trying to do is not just impact the health of our members, but really the community at large. And when you look across those 7 different markets, if you look at the populations in those markets, it's 12 million people. So that's really where the opportunity is. I'm not saying that we've improved the health of 12 million people already, but that's the goal. The goal is that we're going to try to improve health, address chronic conditions, address health barriers that are going to impact communities at large. The next thing is partnerships. I've talked a little bit about this already, but we have our national partnerships. We want to form local partnerships as well. These are some examples of partnerships that we have. In addition to the ones I've already mentioned, we work with CDC, we work with H-E-B Grocery, we work with the American Diabetes Association. So some are national, some are local. Some are national but have local branches, but these are a lot of the partners that we try and work with. We really want to work with people and organizations that are experts in a particular topic, but on the local level that are experts in the local environment. Because some of the communities that we're in are very different. If you think about addressing diabetes in San Antonio versus New Orleans, different culture, different socioeconomic makeup, a lot of different differences. And so what's going to work in one city is not going to work in another city. So it's really important to have partnerships with organizations in those cities that understand the sort of dynamic and what's happening in those communities. As I mentioned before, once we have these partnerships, once we begin to launch new programs and services and coordinating the things that already exist, we get participation. We get people participating in health activities. In some cases, those are activities around conditions like diabetes or COPD. In other cases, it's new programs around addressing food insecurity with food banks, or it could be a transportation project, or it could be any number of other things. And once we do that, we see behavior change. Behavior change can take a lot of different forms. It kind of depends on what the intervention is. But ultimately, if you have a chronic condition, we want to stabilize that chronic condition. Whether you have a chronic condition or you don't, we want to improve the way people eat, and we want to improve the amount of physical activity that people have. If you do those 2 things, you're going to lead a much healthier and longer life. And so this is sort of the ROI model, I guess you could call it, is that once we get improved health, we see lower costs, right? Because people aren't using healthcare services. They're not going to the hospital. They're not going to the ER, so forth and so on. When I say lower costs, I mean lower out-of-pocket costs for consumers. In this day and age, when people have high-deductible health plans and premiums for insurance products and so forth, if we're making people healthier, they're using fewer services, we can offer lower prices. It's lower out of pocket for those consumers. It's also obviously going to save money for us because we're the one paying for the services. But really everybody wins. If we're improving health, everybody wins when it comes to paying. And ultimately that leads to more efficient healthcare spending. So going back to when I talked about we spend $10,000 per person per year on healthcare, and we're getting terrible value for money right now. If we go through this whole process and we address root cause of bad health, and we work more on prevention, we are going to improve health. We are going to lower costs, and we're going to be more efficient in how we allocate healthcare dollars. So that all sounds great, right? But we have to measure progress. How are we going to do that? Well, I mentioned that Healthy Days, the CDC measure, is kind of our primary metric that we're doing. The way we're measuring progress is that we survey nationwide within our membership for now, but we're going to go beyond that eventually, and we established a baseline. So this year, we established our baseline across our membership, across different lines of business, 11.5 unhealthy days per month. And you can see that that breaks out between physical unhealthy days and mental unhealthy days. A little bit heavier on the physical, but mentally unhealthy days is still almost 5. And what that means is that, out of 30 days, 1/3 of them, on average, for our millions of members, are unhealthy by a member's own self-report. Their perception of their health is unhealthy 1/3 of the time. That's pretty significant. And so our goal is to improve the 11.5 by 20%, which will get us to 9.2. Again, that is a really bold goal, hence the name, but it's aspirational. And we may not get there, to be totally honest. But if you say you want to lose 30 pounds and you end up losing 20 pounds, you don't quite hit your goal, you're better off than you were before, right? It's about starting the conversation. It's about realigning priorities and figuring out what we want to work on, what we want to do, what we want to accomplish. And so this is our goal. This is what we're working on. This is how we're measuring it. Another thing that we're doing, in addition to measuring, is that we want to publish our results along the way. We want to publish the things that we learn. There's a lot of evidence already that Healthy Days is associated with actual health, but we've done a ton of analysis as well. And so this was the first manuscript that we published in Population Health Journal earlier this year. And it appropriately titled The Case for Healthy Days. Half of what we did was just kind of say, there are a lot of different ways to measure health and quality of life and so forth and so on. These are all the reasons why we chose Healthy Days. But we also talk in the article about how Healthy Days is associated with actual health. We've done lots of different analyses that show that, as a disease progresses, Healthy Days get worse. And for people that have chronic conditions that are doing the right things, taking their medications on time, controlling their cholesterol or their A1C, their Healthy Days go down. So that's pretty significant. And as we learn these things, we don't want to keep them to ourselves. We, as part of our population health approach and our community health approaches, we want to share knowledge out with the world. And so this is our, first journal article that was published, but we've got lots of conference posters that have been out there, and we've got a bunch more in the pipeline. So just a little thing about that. So the way that we're going to get to that goal is by, like I said, addressing chronic conditions and addressing health barriers, social determinants of health. And that's really what we need to do. And so what I want to show right now is just a really quick video of kind of ties all that together, from town halls to health advisory boards to pilots, and show you kind of what we're doing in our most mature community. We started in San Antonio in 2014, so we're about 2 years in now, and we're still early in the progress, but we're beginning to see some results. So I'll just show you a quick video.
At the Mayor's Fitness Council, what we try and do is create collaborative opportunities. No matter where you live in our community, you're going to have opportunities and access to be able to live a healthy lifestyle. It was simple as just somebody like Humana saying, we're going to put a walking group together for our community, and we're going to go down to this beautiful mission, and lo and behold, what do you know? People showed up and decided what a beautiful place to walk, and there's a regular walking group that this is their track. This is where they come to do their exercise.
Many of the walking groups have people that are new to fitness, new to wellness. We have seniors, we have youth, we have the military, we have mall walkers, deaf walkers, blind walkers, pet walkers, you name it, and they're going out there and spreading the word We're making a difference. We're getting out there.
As we all know, when it comes to health, physical activity is really important, but food is the hard part. We have about 8 million Texans who shop with us each and every week. So first we have to help them understand what is a healthier choice, and then perhaps put some money back into their pocketbook when they make those choices. And so we've just launched this new program for associates here in San Antonio to help encourage and incentivize them by earning points with Humana for all those purchases they're making in our stores. Anytime they buy any fruits or vegetables, they earn points. When they purchase heart-healthy products, they earn points. So obviously it's a win-win because it'll show them that eating healthfully week in, week out can be easy and it can be affordable. We have started to see a reduction in the incidence of adult obesity as well as childhood obesity in San Antonio. So we know what we're doing is working.
Shirts, dispatch from MIH1. Show me en route to...
We were finding that we had trouble with people calling 911 a lot because they didn't know how to access their health care in any other way. So to help solve that, we have a program called Mobile Integrated Healthcare, and that's paramedics going out to visit patients proactively. We have access now to Availity with Humana, which means that our mobile integrated healthcare medics can access when they last filled their medications, when they last saw their primary care physician, lab results, test results, things like that. So it's nice to have somebody that has the medical knowledge and that can come and sit down and actually explain things to you. Our patients are ultimately healthier because we've got the paramedics going to visit them on a weekly basis and finding them the resources that they need and to keep them healthier and living happier lives.
Humana has been a great partner in many different ways by educating people on what it means to be healthy and then creating those opportunities and make it easy for them to do something as simple as go on a walk or how to find access to good fruits and vegetables and to remove barriers that stop people from being as healthy as they can.
Alrighty, and so that's just sort of encapsulates what we're trying to do. Again, that's in San Antonio. I want to end by just giving a couple of case studies, if you will, of how this is coming to life and some of the pilots that we're working on. So diabetes is a really big problem across the country. It's a particularly big problem in San Antonio. If the national sort of prevalence of diabetes is 9% in San Antonio, it's over 14%. That's pretty significant. What we began to realize once we started to look into diabetes in San Antonio is that there is a lot of work going on to address diabetes already. A lot of organizations, a lot of people have developed programs. They're doing a lot of different work and research. But what we found is a lot of them weren't talking to each other. They weren't coordinating. There was a lot of duplication of resources and sort of programmatic themes. And the other thing that we found is that, and maybe because they weren't coordinating, a lot of times doctors didn't know how to refer patients to these programs, and patients didn't know how to access them. So that's a problem, right? Because diabetes is a big issue. There's a lot of stuff happening, but the people that really need it don't know how to access it, right? So the solution that they came up with, once we brought all those stakeholders in, got them involved in our health advisory board, was to form a diabetes resource guide. And this is an online tool where all the different stakeholders are able to put in their programs, their services, their offerings, the location, the time, et cetera. It's updated on a regular basis. It's accessible by providers. It's accessible by patients. And basically, we're serving as a convener, as a way to just put all these things together and put them in a self-serve kind of format so that patients and providers can access it when they need them and know where they can go to get resources. So it's something where we didn't even really create anything that doesn't already exist, other than a curation tool for all the resources. But it was just a matter of getting folks to talk to each other and talk about, well, I'm doing this and you're doing that. How do we work together, and how do we get this all in one place so that patients can access it and improve their health? One more case study that I'll talk about is, I've talked a lot about food and about food insecurity. It's a major issue. It's a major issue in the country. There's some statistics here that you can see. 1 in 7 Americans is food insecure. That's about 48 million people. And that spans across the different age groups. That's children, it's seniors, it's everyone in between. It's a really, really stark statistic that many people in this country, the greatest country in the world, which I really believe in, are food insecure. And another stat you can see there is the annual meal gap. 8.7 billion with a B meals are missed each year by Americans. That is really, really unbelievable. And down at the bottom, you can see there are 14 states that are above the average in terms of prevalence of food insecurity. A lot of those states are where we have our bold goal communities. So you can see Texas and Tennessee and Louisiana and Kentucky are all communities that we've gone into to try to do our sort of community health approach. So one solution that we've come up with through our national partnership with Feeding America is we understand that providers are the trusted source of health information and really almost any other kind of information by their patients. So what we decided to do was to try and partner with providers to educate them on how to screen for food insecurity and then refer to a resource. So what we did was, in partnering with Feeding America, we were able to identify a simple 2-question food insecurity screener and then embed it into an EMR in provider practices. And that's, but that's only half the battle, because what we found with providers and really with a lot of other people is that, they are uncomfortable asking questions that they don't feel they're empowered to address. And so doctors aren't going to want to ask about food insecurity if they feel like they don't have anything that they can do about it, right? So the other half of the solution in working with Feeding America was, well, what if we embedded a resource, for a pilot into a provider practice? And so that, in a real-time basis, the provider is going through the EMR, asking all the other questions. They ask 2 simple food insecurity screening questions. If a patient screens positive, you make an immediate referral into another room to a representative from Feeding America that can educate a patient on how to sign up for food stamps, can educate them on where the nearest food bank is, any other resources that are relevant to, learning how to, cook on a budget, but cook healthy on a budget, or anything else like that. And so that's a pilot that we're implementing in Florida as we speak. It may not be sustainable across the country to have, a Feeding America, representative in every single practice. But when you're scaling that, it could be telephonic, it could be, you can do other things. But the fact of the matter is, we're trying to go through the provider office because the provider is a trusted person. We want them to be the ones that are asking the screening questions, having that conversation with a patient they've built a relationship with, and empower them to do something about it. If someone says, yes, I can't afford my medications, I'm not eating the right foods because I can't afford them, here's a resource. Here I'm going to be able to hook you up with food stamps and with a food bank and with other resources that can help address this, health barrier, is what it really is. And so, it's just one small example of something that we're trying to do. But we're trying to do this with a number of different social determinants of health and health barriers. So, in summary, the journey continues. We have 60 pilots going on right now across the 7 markets that we're in. Some of them will work, some of them won't work. The goal is to figure out which ones are successful in addressing chronic disease and addressing health barriers, and scale them within communities beyond our membership, and to scale them really across the country. That's really our goal. So, we're in the early stages of this. We have a long way to go. Our goal is aspirational, but it's something that we really believe strongly in. It's why we've pivoted our company around it. So that's it. Thank you very much. I'll take some questions if anyone has any.
Hi, Andrew. Thank you for the talk. I was just wondering how long you have committed to this project for. Because obviously, if you've pivoted a few times, it'd be hard for the communities to kind of regroup if you were to kind of pull out in 5 or even 10 years. So, what kind of long-term commitment do you have?
Yeah, that's a really good question, and actually, it's a question that the communities themselves have asked us when we held our town halls in these different communities. They said, it's great that you're here, but are you going to be here in a year? Are you going to be here in 2 years? We are committed to it. We set a 2020 goal, so at the very least, that's 3 or 4 years from now. But I really believe that we have pivoted our company to focus on prevention and health and root cause of poor health on an ongoing basis. When I showed that utilization management, disease management, population health, that's an evolution. Our company is 60 years old, and we've been around for a long time. So I'm talking about decades of change. We are committed to population health. We're committed to community health. And so we are committed in perpetuity, I would say.
Hi, and thank you for the great presentation.
Sure.
I wanted to ask about the elusive holy grail of behavior change. In one of the slides, the step just prior to behavior change was participation in programs. And I wanted to ask if you've measured for a true causal relationship between participation in the programs causing behavior changes that are sustainable. And if you have, how robust and strong was that relationship?
Yeah, that's a really good question. To be totally honest, a lot of our analysis so far has been correlation, not necessarily causation. But we are trying to move in that direction through, we've done a lot of retrospective analyses to come up with these insights. Now what we're trying to do as we launch pilots is to put study designs in, to do pre-post analyses on our Healthy Days measure, on our clinical measures, really to move from correlation to causation. So if through a pilot, if by doing one specific thing, controlling for all other things, RCTs would be ideal. We don't always have the opportunity to do those, but whenever possible, we like to have a control group. We do pre-post analysis, and we really are trying to move in the direction of causation. So I don't know if that wasn't a perfect answer, but
it's probably as good as it can get, and that sounds good.
All right, thank you.
Quick question for you, Dr. Renda. You talked about food insecurity, and kudos to you for trying to work with Feeding America to screen for patients. But from what I understand, there are certain communities that don't even have a fresh grocery store nearby. Mm-hmm. Can we solve the population health problem without marshaling resources from the food industry? Like grocery stores or
yeah,
at least have the fast food industry also in tow?
Yeah, that's a good question. I mean, we've worked with HEB, which is one kind of grocery chain. We have not worked with fast food yet, although that could be an interesting opportunity. It's a hard thing. There are food deserts out there, and we as a company are not going to be able to say, build a Whole Foods here. And even if they did, people couldn't afford it, right? But I think, I go back to something that we're doing in Louisville, not as part of the bold goal, but as part of the metro government in the city where our headquarters are. And we talk about health in all policies. As we think about community development, urban development, planning out how we're building cities, we need to start incorporating health into how we plan communities, right? And that includes walking paths, it includes grocery stores, it includes all those kind of things so that we can, again, make health accessible and easy and so forth and so on. So I don't think it's an easy fix, because there are some places where there are literally food deserts and you can't access healthy foods. We can start to try and do some things, and there's mobile grocery stores we've looked at piloting with, almost like food trucks, only they have, like refrigerated space where they'll come and bring healthy fruits and vegetables and park there for an afternoon. There's little things like that, but I think it really needs to be more systemic. We really need to sort of plan communities better or retrofit communities to address those kind of gaps.
It's a great presentation. Quick question, since I was going to ask you about policies and then you just answered it. Let's have another question, which is, in communities, you have all of these employers, and as an insurer, many of those are your customers, and I know that could then be tricky because a lot of these employers are at risk for their health care, yet they're in these communities. They're another organizer of the people, and they have their own policies and their own values. How do you think about the role that employers in these communities play in this kind of a framework?
I think they play a big role. I mean, obviously, they have the most access to their employees, their associates. And we try and model that, I think, with our associates. So in addition to all these other 7 communities, we are doing this bold goal work within our own associate population. trying to address, health barriers and gaps and so forth and so on. And what we've seen within our membership is that, within our associates, is that we are going to achieve that 20% goal. We've been doing it for a little bit longer, but we're on this trend where we're going to hit our 20% goal. So I say that as an example, but I feel like we should be leveraging employers because they have access to their employees. And so absolutely they should be part of the stakeholders that we have. And honestly, that might have been a little bit of a miss by us in the beginning, because when we thought about stakeholders, we thought about nonprofits and government and faith-based and so forth. We didn't always think about for-profit companies, which is a little bit weird, right? But now we are starting to include those. One, because for-profits are, often, pillars in community, but also because they're the ones that are employing all the people that live in the community. So they need to be part of, the collective impact that we're trying to achieve.
Thank you for your presentation. Back to food insecurity. The data tell us that the majority of senior adults are eligible for but not signed up for SNAP. Mm-hmm. And we think a lot of that has to do with stigma. So what are your providers doing and your community groups doing to try to figure out how to help people overcome that, so that they can access the services and then get...
Yeah, I think that's a good question. I mean, to be totally honest, we're not doing a lot around stigma of it right now. I think, number one, it was recognizing that it was a problem with seniors that we're trying to address. And two, we're trying to connect people with those resources right now. And the example that I gave is doing it through a provider. Once they screen, they're going to show someone how to sign up for SNAP. But it's true. Just like with behavioral health conditions, there's a stigma associated with, food stamps and so forth and so on. And I think it's something that we do need to address. I think we haven't done that yet, but it's something that we certainly need to do. We need to make it less obvious when people are going and spending them to buy food, I think. But it's something that we need to address for sure.
You talked about the transition from fee-for-service to value-based care, and it seems like you have sort of a contained system. Question number one, how are you paying for this today as opposed to cost savings benefits in the future when patients are healthier? And outside a closed system in the community, who's going to pay for it?
Yeah, well, I mean, we're just dipping our toe in sort of value-based care and value-based payments, but there's a whole continuum that you can go down, with all this macro stuff and everything else. And so, the first thing that we try and do is get providers to move into sort of an upside-only kind of thing where we're paying for quality outcomes. We have specific quality measures. There's the PQRS, provider metrics. There's, HEDIS and STAR and those kind of measures, and paying for those. Then as you kind of move down that continuum, there can be a downside risk as well. There's full capitation. There's all sorts of different ways to do it. But that's a question that a lot of providers are asking. It says, you tell me that I can go from a patient panel of 2,500 down to a patient panel of 800. But the question is, how do I make that transition and how do I keep the lights on? And so it's a matter of not just going from full fee-for-service all the way to full risk, full capitation kind of payments. It's a gradual shift that I think you have to make. And you start with upside only, and you gradually, once you've built the infrastructure within your practice, with case management, things like that, and as long as you're supported with the right kinds of data and things like that that enable you to do that kind of care, then you can move further down the risk pathway. It's something that, you asked sort of beyond our membership. Our membership is where, we have the most opportunity to do that. I think we have millions and millions of members across the country. I think if we are moving our providers down what we call path to value, I think we are starting a trend, and I think other payers will kind of get into that trend. I think more and more providers are going to be, willing and able and set up to get in that type of relationship. All right. Well, if that's it, thank you all very much. Appreciate